clinic, we've converted almost entirely to using dexamethasone, which is a slightly more potent and longer acting steroid than prednisone. And we give it actually the IV formulation, which is a bit more concentrated than the oral solution. We give the IV solution orally in our clinic. And you can give a single dose when they're there in the clinic. And then if they have a follow-up a day or two later, you give the second dose, or you can prescribe the second dose as a tablet. So that's something that's really revolutionized our sort of acute asthma management, exacerbation management in our clinic, is the use of 2 doses of dexamethasone over 5 days instead of 5 daily doses of prednisone. But that's something you may already be doing in your clinical setting. Maybe you can lobby your clinical directors to get some of that IV formulation for PO use, because it's been really evidence-based and really helped out a lot.
I think dexamethasone is such a powerful tool for us. I mean, it is so hard to get children to take an oral medication. And so if there's something that we're able to switch from 5 or 10 doses of an oral steroid, which do not taste great, to something that is just going to be 1 dose in clinic and 1 dose for the family to give at home, that really is, I think, making life easier for the parents of these children. And then also giving them this kind of potent, longer lasting medication. It covers them. Each dose has about a half-life, I think, of 36 to 48 hours. So it's a little bit of a blunt tool, but it's a useful tool. Practically speaking, dexamethasone is great. I have used IM dexamethasone many times when they tell me that a child is throwing up the whatever other steroid they've tried to give them. Fine. I just skip it. And if they're there in front of me, I'll give it to them IM. And then generally, once they feel better, they'll tolerate the oral dose a little bit better.
That's right.
And then for prednisolone, things like that, in general, I think I see many outpatient providers sometimes using those medications, which is fine. They're steroid medications. As long as they're dosed appropriately, it's still the correct treatment.
That's right.
The liquid tastes bad. It's bitter. And then sometimes, depending on the concentration, you're asking the child to consume a pretty large volume of a really bitter liquid. So even for young kids who don't usually take pills, I'll still recommend that people give a tablet formulation, crush it.
Crush it in a little spoon.
Crush it in a spoon, give it with some chocolate syrup or some ice cream. And that way you know it's getting into the kid instead of having them throw up or spit out bits here and there.